Thank you, Chairperson. Good evening, everyone. At the outset, I like to thank Allahabad Medical Association, office bearers, and also the members for giving me an opportunity to be part of this August audience and also to be part of this excellently arranged academic program. Once again, I like to congratulate my President Dr. Aviral Saxena. He is one of our best students and also has the ability to take it up as a single-handed diagnostic center. None of our previous students have done that. So I'm very proud of him. And I like all of you to join with me to congratulate him for his successful endeavor. And his success is entirely in your hands. How you are going to use this excellent imaging modality. And one of our small efforts to improve that is this scientific program. Thank you very much for all of you to come and attend this program and also to have a healthy discussion with these people so that the relevance of PET CT becomes more in the clinical practice. So in the next 25 minutes to 30 minutes, we shall be discussing the non-oncological indications of FDG PET CT. So we heard from the experts how relevant and how useful this investigation in oncological practice. I am sure after the next 30 minutes of our discussion, you will definitely get convinced there is a definite role for the FDG PET CT in many non-oncological conditions also. So the FDG PET CT can be used in many neurological conditions, in specific cardiological conditions, especially to assess the myocardial viability before proceeding with a high-risk CABG surgery. It is an excellent tool in our day-to-day practice in the evaluation of pyrexia of unknown origin and also in many rheumatological conditions. It's a great tool, especially for India, in the assessment of tuberculosis, the multi-drug resistant tuberculosis, and also in the good investigation in the evaluation of many granulomatous diseases, especially sarcoidosis, which goes many times undiagnosed in our day-to-day practice. So, of course, we can use two imaging procedures. One is FDG PET CT imaging and FDG PET MR imaging. Even though FDG PET MR imaging is not available in many centers, what you have in your city, the digital PET CT, is a good compromise between this analog PET CT and a PET MRI. It has 80 slice CT, so the image quality what you get from the anatomical component of this hybrid imaging modality is excellent, and you can also fuse the good quality PET images what you get from the digital PET on an MRI, and you can use it in specific clinical situations. So FDG, fluorodeoxyglucose, is the radiopharmaceutical of choice in majority of the non-oncological indications. And the uptake of FDG or fluorodeoxyglucose is facilitated by the normal physiological uptake in brain and abnormal increased FDG uptake by the inflammatory cells by the overexpression of glucose uptake receptors or GLUT proteins that are present more in inflammatory and infective cells. So the more the inflammation, the more active the inflammation and the infection, there is higher FDG uptake. So this is the concept based on which we use fluorodeoxyglucose in the assessment of many inflammatory and infective conditions. So the first relevance of FDG PET CT in neurological conditions is dementia. Progressive cognitive impairment, which is called dementia, is a considerable burden on our healthcare system. And Majority of the dementic patients are interestingly due to Alzheimer's. It can also be a frontotemporal dementia. It can be due to Lewy body disease, and it can be a vascular dementia. I like to get your concentration on this statement. The accuracy of FDG PET CT is too high in the diagnosis of Alzheimer's disease, the frontotemporal dementia, and also diffuse Lewy body disease. So any patient who is suspected to have dementia, the first investigation is not MRI or CT, but the FDG PET. And the interpretation of this differentiation of Alzheimer's, vascular, and frontotemporal dementia is very easy. It is basically a pattern recognition. You are looking for specific hypometabolism or reduction of the metabolism in brain in specific structures. For example, whenever you have Alzheimer's suspicion, you are going to have reduced FDG uptake in posterior cingulate. And the most important is parieto-temporal cortex abnormality or hypometabolism. Whenever you have reduced uptake in frontal, or whenever you have patients with advanced Alzheimer's disease, you are going to have frontal cortical hypometabolism also. You will have normal preserved metabolism in visual and motor cortex. So this pattern can easily be recognized as early as 30 years before the onset of Alzheimer's disease. So mild cognitive impairment, whenever we think in terms of mild cognitive impairment, an FDG PET scan is going to be negative. Many of you can argue with me what is the relevance of understanding the presence of Alzheimer's disease so early, even though it is not curable. You can slow down the progression of the Alzheimer's disease in these vulnerable patients, and that's where the relevance of FDG PET comes. So this is a typical example. You can see that there is normal metabolic uptake in the posterior cingulate and the primary visual cortex, but there is significantly reduced uptake in parieto-temporal bilateral, and in this particular patient, because of the advanced Alzheimer's, there is hypometabolism in frontal cortex also. You can differentiate this from frontotemporal dementia. This is unlike Alzheimer's, which affects elderly patients. The frontotemporal dementia is more of middle-aged dementia, and it has multiple variants like Pick's disease, the frontotemporal, where temporal component is more than the frontal component. And here also the pattern recognition is excellent. You can see that it primarily affects the frontal cortex and the anterior temporal cortex. It has to be differentiated from parieto-temporal hypometabolism in Alzheimer's, and in frontotemporal dementias, it is primarily the frontal and anterior temporal involvement. You can again easily make out this. You can see that the frontal hypometabolism is there, even though there is a very early frontotemporal dementia along with the temporal hypometabolism. Diffuse Lewy body disease, relatively uncommon when compared to Alzheimer's and frontotemporal dementias. It primarily affects the occipital cortex, and you can make out that there is significantly reduced hypometabolism or significantly reduced FDG uptake, mainly in the occipital cortex. So this is another important clinical entity in our day-to-day practice, the encephalitis, autoimmune encephalitis. These patients will be immensely benefited by an FDG PET because majority of the time the autoimmune encephalitis can actually have a paraneoplastic pathology. So you can look forward for a unsuspected primary malignancies like lymphoma, and also you can see anti-NMDA receptor encephalitis. So this is a one-stop shop for both studies. You can assess the hypometabolic status of the brain And also you can look forward for the possible paraneoplastic cause in these patients. Here are two examples. One is a viral encephalitis where there is significant inflammatory hypermetabolism in the affected area. On the other hand, this is an autoimmune encephalitis with global hypometabolism and preserved metabolism in the basal ganglia. So this is a very interesting case, patient presenting with an autoimmune encephalitis, but this particular patient has a paraneoplastic cause, that is the carcinoma lung. So obviously this particular patient's encephalitis will improve only when you treat the primary. So this is a very important information that is provided by this whole body FDG PET imaging. Coming to movement disorders is a very common problem we come across in our day-to-day practice. And one important point I like to highlight in this is the imaging of the basal ganglia, and you are looking for dopaminergic deficits. And for this, you need to use a separate radiopharmaceutical fluorine labeled DOPA. Again, it will be available to you because this can be produced in Lucknow and it will be transported to Allahabad. So this particular radiopharmaceutical also will be made available to you by Dr. Aviral in future. And this is an excellent imaging modality in the early diagnosis of Parkinsonism. We know many of our colleagues and many of our patients really suffer with Parkinsonism, and the early identification is extremely relevant, and it is provided by this simple the PET CT imaging with fluorodopa. Coming specifically to the role of FDG PET in the epilepsy, it has an excellent imaging modality in the patients who are going to be benefited by a surgical corrections, especially with temporal lobe epilepsy. And what you are looking is the area of hypometabolism. So this is very relevant because any patient who is going to be taken up for surgery has to go for a intraoperative electrode placement, and this can be guided by an FDG PET. And the FDG PET is an important investigation, especially in patients who is suspected to have temporal lobe epilepsy, and the MRI is perfectly normal, and that's where you are looking for this hypometabolism. Whenever you have a hypometabolism, you can do two studies. You can do an ictal perfusion study and an ictal perfusion study and an interictal metabolic study, and you can fuse each other and you can exactly map possible area of the temporal lobe sclerosis, and you can go for the surgery. So the exact localization of the disease pattern in epilepsy is provided by the FDG PET study. Coming specifically into inflammatory and infective conditions. So whenever we talk about pyrexia of unknown origin, I'm sure many of the internal medicine physicians will agree. This is a vexing problem in our day-to-day practice. And today, not only the tuberculosis, the infective conditions, there are many other non-infective granulomatous conditions and rheumatological conditions which can present as pyrexia of or unknown origin or infection of unknown origin. And these are some of the areas where you can really use the FDG PET CT. Presence of infective endocarditis finding, the multi-system or cardiac specific sarcoidosis, lymphoma and other occult primaries, especially carcinoma pancreas, carcinoma lung, these all can present as pyrexia of unknown origin. And large vessel vasculitis and sarcoidosis in our rheumatology practice many times goes undiagnosed because we are not looking for or we don't have the right investigation to look for. And that's where the FDG PET CT comes into picture and fills up that void. It has a lot of relevance in sarcoidosis evaluation because it can first differentiate, even in an established case of sarcoidosis, whether the disease is active or inactive, so that you can take a decision when to stop our steroid use. So the patient is responding or not to our therapy, and there is a suspected recurrence, again you can do a FDG PET CT. The common sites like lymph nodes, pulmonary, the lungs, the liver, spleen, bone, skin, and cardiac all can be imaged in one go. And if it can be produced or it can be provided by FDG PET CT, I'm sure you will not go for any other investigation because this is the one-stop shop imaging for sarcoidosis evaluation. Let us see some images, but before that, I just like to highlight very important clinical situation, clinical condition, that is cardiac sarcoidosis. Cardiac sarcoidosis, majority of the time is asymptomatic, but if it is present, patient can present with sudden death. One of the most important cause for sudden death in patients are the cardiac sarcoidosis. And the cardiac sarcoidosis incidence is 15% of the active sarcoidosis evaluation. And today, majority of the guidelines, including the Japanese Ministry of Health and Heart Rhythm Society guidelines, they show and they have established FDG PET as an important imaging modality and a reliable imaging modality in the assessment of cardiac sarcoidosis. Let me show some images to impress upon the relevance of FDG PET CT. So this is a patient where you see an abnormal uptake of FDG in the in the myocardium. And this also patient has multiple mediastinal lymphadenopathy. So these are some of the hallmarks of cardiac and extracardiac sarcoidosis. And this particular patient underwent a whole body imaging showing there is significant extracardiac sites like lymph nodes, bones, and all other sites can be imaged in one-stop shop. And also, it is an excellent tool in the assessment of therapy response. Patient is started on steroids and patient is continued on steroids for 6 months, 6 weeks. Now, patient started with methylprednisolone, is changed to oral prednisolone. But when to stop this oral prednisolone is the answer is given by the FDG PET CT. We have a quantitative marker called SUV max, standard uptake values. In simple terms, how much amount of FDG injected is taken up by the inflammatory cells. If there is a reduction of this uptake by 50%, then you know that this particular patient is responding to your therapy. So this is also a great tool in the assessment of the cardiac viability. As you know, majority of the patients with depressed LVEF with a significantly established coronary artery disease, when he goes for a high-risk CABG, these patients will be immensely benefited by a viability study. This viability study is done with a cardiac perfusion tracer, and the relevance of identifying this cardiac viability is further enhanced by the cardiac PET studies. It is easy to understand the myocardium, normally perfused myocardium, where there is oxygen availability is very high. They are dependent more on the free fatty acid as their energy substrate. But when there is ischemia, when there is reduction of oxygen availability, then their substrate changes to glucose. So they have increased glucose uptake. That's the concept by which we use FDG PET in the assessment of viability. So these viable cells, viable dysfunctional myocardial cells with reduced perfusion. So you can see that they have reduced perfusion. For example, in this particular patient, the lateral wall has reduced perfusion, the circumflex territory, but the same patient has very significantly high FDG uptake in the lateral wall. So this is a hallmark study to show patient has hibernating myocardium or the viable but dysfunctional. You do a CABG, patient's ejection fraction will significantly improve. That is the relevance of this viability study. So as we were discussing, it is a great tool in the assessment of large vessel vasculitis and medium vessel vasculitis, especially giant cells and Takayasu arthritis, mainly the aortic arthritis, it can be picked up, and it has an excellent sensitivity and specificity in the assessment of active disease. And you can actually grade the increased FDG uptake by comparing it with the with the with the mediastinal blood pool and the liver uptake. So you can see that there is active disease involving the medium and large vessels. So you can see that the abnormal uptake in the axillary vessels and also the femoral vessels. So this is an active large vessel vasculitis. So this is a typical aortic arthritis. You can see the entire course of the aorta showing increased uptake. So this after with medical therapy is significantly coming down. So this is the relevance of an FDG whole body imaging in the scientific approach of how to treat this patient and when to stop this treatment. Again, as I told, tuberculosis, this is a patient who was thought to have carcinoma lung, but the patient also has the pulmonary and extrapulmonary tuberculosis. It doesn't mean that to diagnose tuberculosis, I am suggesting FDG PET, but this is a patient with drug-resistant, multi-drug resistant tuberculosis. So when these patients are treated with the higher-end anti-tuberculous drugs, whether they are responding to the therapy or not is shown. So after 3 months of the therapy, second line of ATT, patient is responding. So this therapy response is excellent in this patients, especially the multi-drug resistant tuberculosis. It is also a great tool in the assessment of skull-base osteomyelitis. Again, a vexing problem in patients with uncontrolled diabetes, in elderly patients especially, and also a very important clinical tool in the assessment of diabetic foot. So again, I'm proud to say that our Aviral has done a great work in this, the skull-base osteomyelitis. This is one of the studies which we have published in one of the most prestigious nuclear medicine journal, that is the Nuclear Medicine Communication, British Journal of Nuclear Medicine Society. And this is a far more superior study, whether it is a PET MR or whether it is a PET CT, that is the assessment of the extent and the severity of the skull-base osteomyelitis. So the same thing applies for the diabetic foot also. So any patient with diabetic osteopathy, whether this is a Charcot foot, whether the patient has cellulitis, or whether the patient has osteomyelitis, all three information can be provided by this simple study. You can just inject very low amount of FDG, just 1 or 2 millicurie, and what you need is only a regional imaging of the ankle and the foot. You give all the information, whether the disease is there, that is infection is there, whether what is the extent, whether it is involving only the cellulitis or whether it is an osteomyelitis, and most important, whether it is active or inactive. All this information was provided by this very simple investigation, that is FDG regional PET CT imaging. So what we have learned in the last 30 minutes, it has FDG PET CT is a very, very important, relevant investigation. It can be the cornerstone investigation in the dementia evaluation. It is a very great tool in the assessment of pyrexia of unknown origin. So we are really relevant in our day-to-day non-oncological physicians. I am sure majority of you will agree to the point that this is a great tool in your day-to-day practice, whether it is a lymphomatous, granulomatous, or rheumatological inflammations. It is also a great tool in the specific assessment of infections, like critical areas like skull-base osteomyelitis and the diabetic foot evaluation. Also, it is a good tool in the assessment of whole body, especially in large vessel vasculitis. I hope you would have got convinced that there is a real role for FDG PET. And with that, I like to conclude my discussion. Thank you very much for your patient hearing. And I like you to have any active interaction if you have any doubts. And everyone should read this PET clinics. This has a lot of information on whatever we have discussed in the last 25 to 35 minutes. Thank you very much once again.